NYU Wagner has a long history in public service, both here in New York City and around the globe. For nearly 80 years, we've been helping our students translate their passions into action so they can make an effective and lasting impact on the public good. Our faculty conduct research that changes the way people understand and act on the most important issues of our time. Our 12,000 alumni worldwide, many of them on this call, are applying their education in a real-world context in a variety of fields, and they're making an impact every day. To make an impact, a person needs to understand perspectives, such as the ones we'll be hearing in tonight's discussion. The Kovner-Behrman Health Forum presents an opportunity for the Wagner community, as well as other thought leaders and practitioners, to hear unique takes on relevant, important, and timely issues in the healthcare field. The Kovner-Behrman Forum is one of NYU Wagner's premier events, and it is made possible only by the continued leadership and dedication of Professor Tony Kovner. Tony created this forum 24 years ago in honor of his mother, Natalie Lieberman, who made the series possible with a very generous financial gift in honor of her son and her parents, Dr. Percy Behrman and Mrs. Eva Behrman. Many of you in attendance tonight have also given contributions that have helped sustain this Kovner-Behrman series and related initiatives over the years, and we are very grateful. Tonight's event focuses on an extremely timely and critical topic, the COVID-19 pandemic, and its profound impact on our country, the world, and particularly on our health system. The pandemic has laid bare the cracks and strains that have been long present in our healthcare system. To move forward from it, we will need to discuss and learn about the changes that are needed to our healthcare delivery system. Tonight's forum will explore who is responsible for making those changes happen, how we can use evidence to support the changes, and how we can develop and maintain accountability for performance. Tonight, you'll hear from three distinguished speakers. Svetlana Lipyanskaya, CEO at NYC Health and Hospitals, Coney Island. Dr. Farzad Mostashari, Chief Executive Officer at Eladad, and Andy Shin, Chief Operating Officer at the Center for Health Innovation at the American Hospital Association. We'll be sharing a link to their bios in the chat. Each of them will speak, and their presentations will be followed by a discussion moderated by Wagner Clinical Associate Professor of Healthcare Management and Public Service, Carla Jackie Sampson, who is the Director of our Health Policy and Management Program and of our online Master of Health Administration program. We will close with a Q&A, and we encourage you to submit your questions via the Q&A button. It is now my pleasure to turn this over to Professor Sampson. Carla?
Good evening, and I join Dean Gleed in welcoming you to the 24th Annual Kovner-Behrman Forum event. I am Professor Carla Sampson, and as you just heard, I am the director of the suite of health programs here at Wagner, and those include our online MBA as well as programs in management and policy in the healthcare space, which makes this event very pertinent for us this evening. I am honored this evening to moderate our FAIR panel, and for the very first time in a virtual format. And we have a lot to cover tonight, and I want to leave ample time for questions. And I really want to encourage you to put your questions into the chat at any time so we can get to them at the right time. But so let's get right to it. To begin, let's have our panelists describe for us their experience from the past year to provide some context for our questions tonight. Let's begin with you, Svetlana.
Thank you, Carla, and thank you for inviting me to be part of this forum. The COVID experience has been very real here at our facility. Our first patient showed up at our door on March 12th, and frankly, it hasn't quite stopped since then. It's been over a year now. We celebrated or acknowledged that unfortunate year-long mark. COVID, in the beginning, it was quite interesting. We're part of the health and hospital system, and so we had begun to prepare earlier in the year in January and February, and then when the patients started coming to Elmhurst, it was this very eerie time because we all knew it was here, and it was very real at that point, but it hadn't really hit any of our doors yet. And so we're watching and we're seeing what's happening and starting to take patients in from our sister facilities. And yet our neighborhood wasn't really affected as much. But then very quickly thereafter, COVID reared its ugly head on our doors as well. And just to give you an idea of the effect, we are a 341 certified bed hospital. At peak of the first wave, we had 445 inpatients in our hospital at a given time. Our emergency room was so full that we actually put up a tent in our parking lot. It's the size of a small field hospital, and we ran a secondary ED out of that tent. And at one point, we had 50 or 60 patients being taken care of in that space in our parking lot. We had 115 ventilators going at any one time. That's a huge number. On a regular everyday basis, we might have 20. So the scope and scale, the amount of oxygen that had to be delivered here was 2 to 3 times more than ever before. One of our sister facilities actually had their oxygen tanks freeze. They were being used so much that they started freezing on the outside. Our staff was highly affected. We had quite a large number of staff who ended up going out sick or in quarantine. And we brought in hundreds of staff from across the country. And frankly, we're grateful that they showed up, because I'm not quite sure we could have all gotten through that first wave without their support. So the country really stepped up for New York during that first wave. And so that's what it was like. Testing wasn't quite so prevalent. So we really didn't necessarily know what we had at any given time, and figuring out how to keep patients appropriately safe was a very big challenge, because you have patients converting. So how do you separate patients? This is not a brand new facility, so we don't have single bedded patient rooms. And frankly, at that point, every possible space that we could was being used for inpatient care. So there was no such thing as single bedded rooms, even the ones that existed. And so that was COVID. That was wave 1. And we survived. Our teams really came together. Everybody stepped in and stepped up. I'll give you an example. We had to suspend visitation, and that's frankly was heartbreaking. And the families really didn't know what was going on, because all the care teams were on the floors running and taking care of patients. So at one point we had close to 300 family phone calls coming in on any given day. This is above and beyond our regular sort of volume of family questions. So we deployed our dental residents to make calls to families. So everybody who had 2 spare hands, including my own, were somewhere on the units helping in the COVID fight, and our team was tremendous. I'm grateful for them every day. And so then wave 1 subsided, and everybody took a breath and focused on, what do we do now? This isn't over. It's going to come back. How do we get ready? What did we learn? And so we actually learned quite a bit. And out of that first wave, we made a number of infrastructure changes to really prep ourselves. Things like putting in vision panels into our patient rooms, so that the patient can have privacy, but yet we can actually observe them from outside the room if we needed to. Putting in dialysis boxes so that we could turn more of our rooms into ICU rooms. We're actually in the middle of putting up a brand new hospital building on our campus. And so one of the things that we did was look at the plans for that and say, well, in light of this, in light of COVID, what do we need to do to make it a facility as ready as possible, right? So negative pressure became a very big deal. And again, vision panels, dialysis boxes, we can now have, once that building opens, 80 private rooms that we can turn into ICU rooms if we need to. I hope we never have to, but we can. So one of the other things that we did, which was actually really important, is talk about communication. So during the first wave of COVID, it was, frankly, it was survival. What's the next patient? What's the next task? How do we get from here to 5 minutes from now? So when we had a moment to sit and talk, it was really, how do we communicate better? How do we build these teams so that things are seamless? What worked? Digital tools worked, our cell phones worked. So nobody really had time to sit at a computer and write each other an email, but you could get on WhatsApp and say, come take a look at this patient, or I have this issue, how should I deal with it? And so we really talked about what tools we could use in healthcare that, frankly, maybe we weren't necessarily using as actively before. During the second wave, we unfortunately hold the honor in the health and hospital system as the facility that has the highest positivity rates. And we sort of had the highest number of patients throughout the second wave of COVID as compared to our sister facilities. And it's been very interesting because, frankly, even with the highest number, it's nowhere near where we were in April of last year. But also the lessons learned have been tremendous. There's so many more options for taking care of our patients. There's so much more knowledge. And so we're able to really focus a little bit broader. We continue to send a message, we continue to take care of our patients, but we're able to continue to plan for the future as well. And so I find that very encouraging, even though here we are not quite out of the situation yet. So far, we're really focusing, as I think everybody else is, on testing and on vaccinations. We've vaccinated over 20,000 people in our vaccination center on our campus. We've done something like 60,000 tests, and we continue to be open for our community. And I think more than anything, this whole entire situation has strengthened my belief in the public healthcare system. I think Health and Hospitals has played an incredibly important role in the New York response to COVID, and the fact that our doors are always open to whoever walks through them makes me really proud to come to work here every day. So that's a little bit of where we've been. And with that, I'm happy to turn this over to Farzad Mustashi, who's our next speaker.
Thank you so much. It's awe-inspiring to hear from you what happened on the ground at one of the epicenters of this. I work at Aledade, where we don't deliver care directly. We partner with and we work with primary care practices across the US in 35 states, 800 plus primary care practices. And before March 11th, what we worked with them on was population health. It was, how do we create an opportunity for them to thrive by taking better care of their patients so they had fewer hospitalizations, and they, under these alternative payment models, if you have value-based models, if you can prevent a hospitalization, you get to keep some of it, which for primary care makes a big difference. So we would work with our practices to do things to help keep their population healthy. And then comes COVID. And, it was March 7th when I was at New York City for 10 years at the health department, and I set up some of the surveillance systems at the time that are still running to this day. And there was a website we created for, it's called the EpiQuery system. And it's still today, if you Google it, you can go EpiQuery syndromic surveillance, and you can see trends in emergency room visits in the city. And on March 7th, I just remember that moment with such clarity. I kept refreshing that webpage saying, like, is it like, we're not, there's talk of COVID, there have been 2 diagnosed cases in the city, but nothing's happened yet, right? And then that day you saw that it was twice what ILI rates had been, and it was doubling every 3 days. And I was like, oh my gosh, like there were tens of thousands of cases in New York City where we thought there were 2. And we just went into incident command mode at Aledade. And what we did was basically think about, what do we need to do to protect these primary care practices? And one of the things I want to have the audience understand is half of primary care in this country is still delivered not by hospitals and health systems. It's delivered by independent community-based practices, private offices, clinics, federally qualified health centers, right? Like these are not part of systems. And as much as systems suffered, these practices were also on the front lines. And like their supply chain was broken. They couldn't get masks. They were literally scotch taping, masks to their face because they couldn't get N95s, and they were getting infected and they were dying on the front lines. And so our company, who was, data-driven healthcare provider of whatever, like we became purveyors of like, find how to import masks so that the people we work with wouldn't die. And like, that's what we imported and donated $1.2 million worth of PPE to these frontline practices because no one else stepped in. And that, like, it is a disgrace for this country that again and again and again, these community independent practices have been put like, no one, there's no plan for that, Telehealth was the second thing, where like we told their patients stay home. They told their patients stay home. So, but how are we going to deliver primary care? So we stood up 150 practices in one weekend. We integrated telehealth into our software, and up to half of their visits then became telehealth, which became essential for them to also not just continue to deliver primary care, but for them to not go out of business. Because that's the other thing. They don't have any reserves, right? Like they literally have to start laying people off in the middle of the pandemic. They're laying people off and they're closing their doors because they're going out of business, because their business depends on people coming in and having a 99213 office visit and billing, someone $84 for that. And if you stop that, counter ticking, you go out of business in very short order. And then helping them navigate all the loan programs and the PPP and the, advanced pay options and so forth. So that's what we did. Like and we did population health, right? It was like calling people who are at high risk for COVID, seeing people, doing wellness when you can, following up on ER visits and hospitalizations. And what's crazy is like it turned out like value-based care there was no problem. Like you could continue to do value-based care and you could continue to do value-based pay. And many of our practices come August, September, when other practices were really suffering, they got, several $100,000 checks, not for seeing patients, but because they kept those patients out of the hospital. And so I do think, so anyway, that's what we did. And now, those practices have stabilized. They're still like, there's no plan for them to get vaccines. Like there is no, like the national vaccine distribution plan has pharmacy chains and it has states, and states go through health systems. And, our docs would love to be able to give vaccines to their patients, right? And they can't get vaccines to give to their patients in most states. They're left out of that also. So they're still there. They're still in those communities. They're still providing the necessary primary care. And often many places they're the only providers of physicians in those rural communities. They're facing a lot of pressures, but they have been on the front lines of this pandemic. And they're our heroes. They're who we work for. That's the story of the past year. Let me turn it over to Andy to talk about his perspective from the American Hospital Association.
Thanks, Farzad. And thanks to Dean Gleed and Dr. Sampson for having us. Andy Shin, COO of the AHA Center for Health Innovation. We're the member support arm of the AHA. And, it was a little more than a year ago that we went remote and formed a war room at the AHA. Two war rooms, actually, one to really focus on the federal response to the pandemic, working with CDC and the administration, as well as a member support war room, which is what I led at the AHA, really focused on things like infrastructure, resource tools, data, other types of partnerships that we could foster with technology companies or others to get those resources out to the field. And reflecting on what Svetlana and Farza just talked about, it occurs to me that one of the things that the pandemic has done for the healthcare field is it really force functioned innovation and related to that force function collaboration. We certainly, and I'm sure we'll talk more about the different technological and digital tools that Svetlana talked about. And when Farzad was talking about PPE, I still have PTSD about just what an awful situation that was, and really how it exposed a huge weakness in our country's infrastructure. And one of the things that we heard early on from a FEMA official was our national emergency pandemic response system is really set up for localized regional events, a hurricane, an earthquake, something of that nature. We have not been and we're ill-equipped to respond to a pandemic of this scale that is so, in some cases, even-handed, but universally felt by the entire system. And so PPE being one of those early examples where we partnered with a whole host of folks that I think is sort of worthy of describing just as an illustration of that force function collaboration and innovation. Early on, there were a lot of individuals who worked at everything from supply chain, manufacturing companies to technology. There were people who were in finance who were either working on the side or were temporarily furloughed. And they said, what can I do to help out? And I can tell you that there were no less than 24 startups in the early months of the pandemic for folks trying to source PPE, find in another country some place where you could obtain KN95s, gloves, gowns, what have you. Domestically, many universities, MIT developing by a magnitude, order of magnitude cheaper face masks that could be easily shipped across the country and manufactured using easily found materials, to what I'll call novel manufacturers, furniture manufacturers in different parts of the country that were no longer making couches, but could redeploy their manufacturing lines to make gowns or masks and face shields and other things of that nature. And so what we did early on was we tried to catalog all those different startups who, of course, were in many cases overlapping and adding a ton of redundancy, because as far as I've mentioned, there was no coordination, there was no infrastructure. We certainly weren't getting that direction from the federal government. I hate to talk about it, but let's not forget that there were also a lot of people taking advantage of the situation too. And amidst all that chaos, there were certainly, unfortunately, some bad actors who were doing everything from price gouging to manufacturing different scams that took advantage of the desperate need that our healthcare frontline heroes were desperate to obtain. And I'm not going to rehash what you all have read over the past year or so in the news about that. It's been pretty well documented. But in contrast to that, some of the collaborations that we were able to participate in, I'll give you one example: Providence Health System on the West Coast, which for all accounts and purposes probably saw patient one in the United States up in Seattle or in Kirkland, and had the brunt of the early wave. They realized quickly that they were not going to have enough PPE. And so they did put out the specs they actually re-outfitted their quality department. Their chief quality officers became all of a sudden an expert in PPE to work on how do we, in a safe environment, manufacture PPE using novel manufacturers, in this case, Cast Furniture Maker in the Washington State area. And how can we put out those specs out to the rest of the country so that anyone else can make that material and get it to their local healthcare providers? Obviously not, and how do we get them the medical grade materials and all of those kind of things? And that became the groundwork for something called the 100 Million Mask Campaign, which became a little bit of a national movement. Related to that, we had a couple companies, Microsoft, AT Kearney, UPS, Goodwill, Merit Solutions come together and say, could we create an app that will predict, because of the uneven nature at that time of COVID-19, who will need PPE, so that when you had banks donating PPE and others donating PPE, we want to know where it can go to besides our local community, who really needs it today. And those companies banded together and worked with us to be able to try to predict who would actually need and how we could get it to them in the most efficient way. One other example I'll provide, just because I think it's illustrative of what could possibly happen in the future in terms of supply chain and infrastructure, is the whole issue of ventilators. And as you can remember, we were at a point where we thought we were not going to have enough ventilators. Many health systems, so Atlanta, I don't know if you had to do this yourself. I know that New York, there was a lot of talk about, do we need to talk about medical ethics? And if we have to choose who will get a ventilator or not, how do we make that choice? A terrible situation to be in, but that was how dire it was at the time. That spurred a collaboration with the federal government and others to create what we called a dynamic ventilator reserve, which is a really simple concept. Let's inventory unused ventilators, because again, many places were not experiencing the surge, and say, could we tag, ship, and rent, for free, unused ventilators, so that as you saw different pockets of surge around the country, those ventilators could be shifted around instead of having to rely on Defense Production Act or other mechanisms to try to get other manufacturers to produce enough ventilators. So these are just two examples of, I think, where you saw collaboration, you saw force function innovation that could be instructive for future infrastructure changes that create more resiliency in the system. But I think are also good examples of how the health system really worked with other stakeholders to respond to these terrible situations. But love to talk a little bit more about other issues. I know we'll get into it. I'm going to sort of end there and turn over to Dr. Sampson. Thanks.
And thank you, Andy, Farsad, and Svetlana for sharing with us what you've experienced in the past year. And where we landed there was sort of thinking about all the lessons that we learned in the last year and how we can take them forward. So let's start with that question. Thinking about the changes that you've all had to make, from practices and processes, the digital tools that you've had to deploy quickly. Andy, you were just talking about some of the partnerships that had to start up. What do you think should or will continue in the post-pandemic era? And let's start with you, Andy, since you were talking about partnerships just now.
Thanks. I'll mention two things out of many. I think many things are going to change, and I really hope that they do. The first thing is you can't ignore what has happened in terms of consumer, but more importantly, I would say provider acceptability and adoption of virtual health and digital health tools. I think, as much as we said, well, consumers will never want to go virtual, I think we all can admit that providers were just as big of a blocker, if not more so. But, we tried it, it didn't break. Some people really like it. I don't think it's a universal sort of shift that we're going to see where everyone's going to be using telehealth only. I think that it adds another level of convenience for those who want it, and great, that's a really good thing. And I don't think that genie is going back. I think what now we're going to be looking at is how to refine the use of telehealth and other virtual modalities, how to actually do it to improve quality and not just as an access point. And that is really, I think, a huge set of areas for research and opportunity, working with payers and others to sort of develop that strategy. The other thing I would mention is in terms of what changes are being made, I would sort of put it this way: attitude. I can remember hearing very early in the beginning of the pandemic, there was in the Midwest, a hospital where they were out of PPE and they did not know how they were going to get more PPE. They're thinking of all these solutions. And so then an enterprising nurse said, well, part of the problem is that we have to go in and we have to sort of check vitals and we have to, change around tubes and all this sort of stuff with the patient. And The problem is that all the machines are in the room with the patient, and that's why we need PPE. So could we drill a hole and put the tubes on the outside? And for all of you who work in healthcare and in hospitals specifically, gosh, that's like a 6 to maybe 2 year enterprise of plenty of approvals. You have to get probably general counsel involved. You might need the CEO to step in. But because of the nature of the pandemic, these things were happening in days and weeks, not months and years. And this is more optimism than what I think will happen, perhaps, but I really hope that mindset doesn't go away, that we don't have to be in a crisis to act with a little bit more aggression towards doing things differently. I think that because we did it, it didn't break. Again, people sometimes even like those changes. It just shows that we don't have to do things the way they've always done in healthcare, and that the mindset shift is something that actually can be harnessed for good.
Great, thank you, Andy. Svetlana?
Sure. I agree, Andy, with everything you said. I mean, clearly healthcare is moving in large part to alternative settings. So we are going to be providing more and more care at home. And that could mean many different things. That could mean, infusions at home or wearables. You don't really need to come in to have your blood pressure taken. There's no reason for that. And so places like mine are going to have to figure out how to make that work and how to really provide sort of targeted, specialized care where the patient wants to get that care. And I think that's very much a mind shift. I've been on the outpatient side for many years before sort of transitioning to inpatient care, and it was very transactional, right? So yes, you need you need more medicine, you need to come in, and you've already had 3 refills. It's time to come in so that we could check on you, but it doesn't really make any sense to do that. So figuring out what somebody has to be seen in person for versus what's absolutely appropriate for digital health, that's going to take a little bit of time, because we made such a huge shift to telehealth, and then some facilities sort of bounced back a little bit, right, and maybe brought a little bit too much of that care back into the spaces and actual in-person visits, that I think it's going to bounce back and forth a little bit until it settles. And it's always going to be here. I don't think there's a way back, and frankly, there shouldn't be. To comment a little bit on innovation, you're absolutely right. The biggest problem with the machines out in the hallway is that there was no tubing. All the tubing was too short. And so I think everything's going to have to adjust. Our supply chains are going to have to function differently, because you're right, innovation is going to move at a different speed. But hopefully regulation allows us that flexibility. I think that was a very big part of the reason why there was as much innovation as there was. A lot of regulations were relaxed during particularly that first wave. And so it gave us the freedom to try things, which, without having to do 48 different jumps through hoops. And so hopefully things will kind of move in tandem, because one piece can't move without the other.
Thank you, Svetlana. Farzad?
The healthcare can change concept is fascinating. And yeah, I mean, I've been around healthcare for a long time, and things just take years and years before you see, and you got to be patient. And then it's like, no, wow, we could change things literally in days. So that's great for all the optimists out there and the students. Like, healthcare can change. We should continue to believe that. A couple of things that I want to add here is bringing in public health. And I'm a public health doctor. I trained in public health, and I've always lived in between the kind of public health and healthcare communities. And it has been really nice. And I hope it continues to see this greater recognition of the role of healthcare in public health and interest in public health on the part of students. We have now millions of Twitter epidemiologists. It's a fantastic development. So I hope that continues. Another public health thing that's been like under recognized story is like there's been like virtually no influenza. There's, like if we keep some of these social distancing and mask wearing when we're sick and so forth, hand washing habits, like we could really like wipe out tons of seasonal infectious respiratory viruses, which would be fantastic if we could learn to do that. And then finally, some of the scientific innovations that have happened here, and in particular the mRNA vaccines, like I was reading, like it could contain the secret to, vaccinating against malaria. Like we would save more lives from a malaria vaccine than was lost in this terrible pandemic. So I'm an optimist. I think there's lots of things that we can carry forward from this pandemic that put us in a better place.
There's something that you mentioned there that I want to tease up a little bit more right now, which is, what is really the responsibility of the healthcare sector to public health? What would you say?
Yeah, I mean, I remember I literally remember where I was standing when I was on the phone with his doctor, and I was trying to get him to fill out a case report form for a nationally notifiable communicable disease that we got the lab results from, but there had been no case report from him for this. I think it was listeria. And he diagnosed listeria in a patient, good for him, but he hadn't told the health department. And I called him up and I was kind of like, so, I'd like to at least interview you to get the details of this case, because it could be an outbreak. It could be a food thing. And he said, are you going to pay me for that? Yeah. And it was like, oh my God, like, that is not what I expect. Like, that is not what I expected. Right. And my immediate feeling was like, police powers, public health has police powers. We shall, I will stamp, and then I realized like, that's not how he sees his job. And the healthcare system, like no one's paid to be a better public health agent of public health, right? It's just part of the professional ethos. And if we lose that professional ethos, then what do we have? So what is the responsibility of healthcare to public health? I think we have seen, and so part of the program that I rolled out in the US was this program called Meaningful Use of Health Information Technology. And we said, look, if you want to get paid for putting electronic health records in your hospital, you should, as part of that, you should report diseases to public health, right? If you're a primary care doctor, you should report immunizations, you should report syndromic surveillance, you should report notifiable lab report results. And we created this infrastructure, but what we didn't do was actually fund public health on the other side of it to be able to receive those results and do something with it outside of places like New York City. So I do think that the primary responsibility when it comes to healthcare and public health is to be good communicators and to share that information and share that data in interoperable ways. The second is a little bit, and this is around pandemics and so forth, but the second is, what can healthcare do to save the most lives? And I would ask your students, do you know the answer to that question? What can healthcare do? All the stuff we do, the $3.6 trillion we spend, what is the most effective way to increase life expectancy and decrease the number of premature deaths in America from healthcare? Do you know what it is? Do the boards of hospitals know what it is? In my experience, they don't. It's controlling blood pressure is the answer, right? And so like we're controlling blood pressure 65% of the time. So like if we think of the role of healthcare as public agents of creating public health, then we're asking an entirely different set of questions than we're asking now.
Thank you, Farzad. Andy, did you want to add anything to that, or should I ask you a different take on that sort of a question, as in thinking about what Farzad just said and given what we should be getting out of our healthcare system, how about I ask you, what is or should be the role of government in healthcare? And what are the priority areas moving forward?
That's an interesting question. So, and I served in government, both on Capitol Hill and at CMS. I was one of the first employees at the CMS Innovation Center. And I can tell you in the early days of starting that organization, which was designed, it was a creature of the Affordable Care Act. And it was designed to test new payment and delivery models with the hope that if we found ones that work, that we could scale it. I will tell you that there was a lot of optimism at that time that this was going to solve everything, right? This was the answer, that if we could just provide an on-ramp for the healthcare delivery system to test out these different models, that we could really transform care as we know it and finally, bend the cost curve and get to financial alignment and make quality and outcomes much better in this country relative to the costs that we pay, the costs that are in many cases increasing, out of proportion. And I'll tell you that one of the realizations I've had, both at my time in the federal government and outside of it, is that it really does take and we talked earlier about force function collaboration. It really can't happen at the behest of a payer, even if that payer is the federal government. They're a really important stakeholder. But for as much as you see, and Svetlana may be an exception to this, but as much as you see hospitals, for example, participating in value-based care, and their high percentages participation in APM, but that's really the wrong measure. When you ask how much of their dollar is actually under risk, it's a much smaller percentage. And so it's a misleading characterization to say that, we're all testing out new APMs, we're moving towards value-based care, partly because other payers aren't there, there are other forces at play. And so in terms of where the federal government, it's a roundabout way to say that I think the federal government can lead in many cases. In some cases, they can remove barriers. Svetlana just talked about the removal of regulations to spur innovation. In some cases, they can be a convener of different stakeholders, and in other cases, they can be sort of just adapters of what they see in the private sector. The model that Farzad is building, what can the federal government learn from them, and how does that inform policy? As one example. So I guess I'm at a place where I think it's very difficult to say that things happen just because they're spurred by the private sector or new entrants and disruptors, where the government can't do it alone. It has to be done in partnership. And as cliche as that might sound, I believe it more than ever as a result of the past year.
Thank you, Andy. And Svetlana, how about I ask you, seeing that you were on the front line and saw what happened in your neighborhood in New York to all the people seeking care. What we saw across the nation is that the pandemic kind of ripped the Band-Aid off all of the inequities that we saw. No longer we were looking back to mortality data around mother and infant mortality. We're looking at COVID data. So now that we see the inequities that there, how should healthcare delivery be transformed to meet the needs of the people who were affected most last year?
Well, I think first and foremost, I think we all have to acknowledge that there are inequities, and it's not just in COVID. I mean, I could certainly talk about, going through our units and seeing who was in our beds, and it wasn't a representation of what our typical demographic is. And it wasn't really a representation of what our community is. It was a lot more Black and brown faces, and a lot of really young Black and brown faces. And that's terrifying. But and I think everybody will talk about, the fact that it's not just healthcare, right? It's housing and education and jobs and frontline workers and all of that. But if we really want to just focus on healthcare for a moment, we have to acknowledge that this isn't just COVID. And we have to acknowledge that healthcare and healthcare education and our protocols have a piece in all of this. There is such a thing as race-based medicine. It's part of what we're teaching future providers. There are risk factors that are measured on, at least partially, on the race of the individual. And they're adjusted up or down based on the race. VBAC risk factors, UTI risk factors in babies, kidney function, spirometry, you name it. There's many of these things that are at least partially driven by the person's race. And is there a role for that in healthcare? Or maybe we sort of start from an equal point and look at the individual and look at every single individual equally and look at their risk factors equally. So I think some of these things are really ingrained even before providers hit the ground and see their first patient. So there is a role for us to honestly look at how we provide healthcare and how we judge our patients and their risk factors before we even look at them as individuals. So in addition to that, sort of staying on the theme of education, there's been lots of research done that when people get care from providers that look like them, the results are better. Their health is better. And I think we have a role in that. There's already going to be a huge shortage in healthcare providers in the coming years, but how do we make sure that we build a pathway for minorities to become doctors, to raise their communities, to see the patients in their own communities? So it has so many different levels that COVID just highlighted, but it was all there. This isn't news. But I think now there's an opportunity to really look at things a little bit more holistically. And frankly, I think we all have to be a little bit honest with ourselves that this exists. We have to address it head on, and we have to move forward.
Thank you, Svetlana. Now, I see that our audience has been quite busy in terms of giving us things they want us to tackle. So here's the first question, and this one is kind of near and dear to me because of my interest in healthcare workforce, which is there a plan to prioritize employee mental wellness or prevent burnout given the circumstances they've been working under in the last year? And that's something that's always top of mind right now.
So can I start with that one?
Yes.
This is a very, very big deal for us. Clearly, and I'm sure Farzad will agree, clearly these people have been on the front lines. The things that they have seen on an everyday basis over the last year, they've never seen in their life. And I think I talk often about healthcare providers losing some of their innocence because while we're used to seeing people get sick and some get better and some not getting better, the scope and the scale is unprecedented. And I think if you talk to ED docs, they are used to kind of, we triage, we get the patient better, we send them home, or we send them to the unit, and they weren't used to necessarily seeing such a quick deterioration in their patients ever before. So I think on top of which there's this real sort of personal concern. I don't think anybody ever came to work in the hospital afraid for their own health and well-being. But we did, starting March last year, absolutely, every day, all the time. I mean, you should have seen the outfits. No matter how much PPE we handed out, it got very creative around here. They put on the PPE we handed out and 5 other layers on top of it. So I think that burnout and that fear, it's very real. PTSD in healthcare right now is very real. And it's very personal to a lot of people. And I think the best thing we can do is talk about it and encourage people to address it. I think as a profession, we don't necessarily encourage healthcare providers to seek mental health. We don't, and particularly, if you look at credentialing paperwork, it's a question. If you're a doctor and you're going to go work to seek a job at a new facility, at a different facility, one of the questions you're most likely going to be asked is, have you had mental health care in the past? Right. So there are, you're almost sort of discouraged from it. And frankly, so people cope in different ways and some don't cope well. I think we need to be, again, kind of open about the fact that, these are human beings who have been through a lot. And we need to encourage and all different kinds of help. So we do a lot around, discussion circles, healthcare wellness rounds. We've started encouraging people to take time off, and it almost feels like no matter how much we do, it's really not enough. I think there needs to be sort of a shift in the recognition that doctors are people too, and so are nurses, and so frankly are the EVS workers and the dietary workers and other people who work in these healthcare settings. And I think somewhere in, they get lost, right? So there's been a lot of acknowledgement towards doctors and their heroic work, and nurses and direct providers. But if you don't have an environmental service worker who's going to go into that room and clean that bed so you could put the next patient in that bed, you're in a world of hurt. And I think that we need to recognize that because, and they tend to be very often minorities, much lower paid. So there's even inequities in kind of recognition. So I think we owe it to them.
Yeah. Thank you for giving such a detailed answer to how we should focus there. Now, there's a question here about what we saw last year in terms of thinking about the people who have avoided care in the last year. And the question is there a model that can estimate the level of mortality that occurred in response to patients either foregoing care or having their care delayed as hospitals triage non-COVID care?
Really interesting health services research question.
Yes.
There was some interesting data from the EMS system in New York City. Actually, that was the first system that I set up public health surveillance on. And it's a wonderful, obviously, service, and they have very good data going back a long way. So you can build statistical models and see like what is aberrant. And there was a really big increase in out-of-hospital deaths with cardiac arrest. And the concern at the time was, is this people foregoing needed care? They're afraid to go to the hospital. And so they're having heart attacks and arrhythmias at home and dying. And it turned out that it was most probably the direct impact of COVID infection, not people not getting needed care, because it almost perfectly matched the epi curve of COVID positivity rate in New York City. By and large, what this pandemic has shown is how much care wasn't really needed. I mean, I don't want to say that like we had a lot of foregone care that wasn't needed. Obviously, childhood vaccinations are like a real problem if you forego them. But there was also like huge drops in utilization that I don't think there's any evidence they caused any harm. And so we got to ask ourselves, like, well, then why are we doing it? And do we need to keep doing it outside of like needing to keep supporting the industry? You know what I'm saying? So to me, that teasing out, and this would be a great health services research, maybe John Billings can do this, teasing out what are the things that that turns out like there's a lot more unneeded care in the system, and you take it away, nothing bad happens to people, versus what is the care that was foregone that actually had a negative impact, would be super interesting.
Thank you, Farzad. And I'm keeping my eye on the time. I know that this would be a very, very engaging conversation and the hour would go real fast. So maybe we can take one more audience question. And that question that I'm going to choose would be, how would each of you assess the role of the Greater New York Hospital Association, the mayor and the governor in getting New York City hospitals to share the burden of dealing with the sickest patients over the past year? Real thinker question. Should they have a role, and what should that role be?
Well, so from my point of view, they do have a role, and they've always had a role. And I think the one thing that COVID has really shown us is the need to function cross-system. And I think we really kind of benefited from altogether from some of that work. And so maybe their role is in that. It's in breaking down some of those barriers during the time of crisis, and helping us all function as one healthcare system.
Thank you, Svetlana. Andy, anything you want to add there?
I can't speak to New York City in particular, but I just want to answer the question that Farzad answered, or the question was regarding predictive models.
Yeah.
I agree with Farzad, by the way, the interesting health services research question, but there are some models out there that are really well done. One in particular, there's two that I know of that are in pretty wide use. One is out of the MIT COVID-19 Policy Alliance, and Restef Levy is, I think, the lead faculty member on that particular tool, on that model. I happen to know because I know where he got the data from, I think, and then also University of Washington has a model out there that's pretty interesting. And so I'm sure there's many more models out there, but just to respond to that. In terms of, I'll sort of answer a different question about sharing burden across the country.
Great.
I think that again, you've seen incredible amounts of collaboration, and not just amongst hospitals and health systems, by the way. You've seen it across different provider settings and even non-provider settings. But when you look at Charlotte, North Carolina, and the mass vaccination they had down at the Bank of America Stadium, for example, and you're seeing that model being used all around the country now. Hospitals aren't talking about market share and competitiveness right now. They're talking about how do we get the job done, and and that relates to things like vaccinations, but it also relates to things like what we were just talking about in terms of equity, diversity, and inclusion. These are community problems, and they can't be solved through rivalry. They need to be solved through collaboration and sometimes through co-opetition. But I think there are some things that we need to realize are done much better together, and that includes public stakeholders and the private sector, including the healthcare delivery system. And so I think you've seen a lot of good examples of collaboration happening in terms of responding to this pandemic.
I'm also not going to comment specifically on the New York City situation because I wasn't close enough to it, but I will say one thing the pandemic has shown is the importance of political leadership and how they can be incredible for bringing people together and creating collaboration, and that politics can also be terrible in a pandemic when political leaders, elected officials, are thinking politically. And I don't think, I'm not one of those people who says like, well, we should let the public health leaders make the decisions, right? Because at the end of the day, these are normative values. Which one do we value, schools more, or the probability of people dying? Like, well, that's it. Like someone's got to make that call, and it shouldn't be the doctors. Don't know what the value of education is or a value of lost education is. Like, that's not our job to make that call. But But I think we've seen really, really pernicious effects of politicians acting like politicians during this thing. And I don't, you know, it's like, we don't know what we need them, but we deserve better, I guess what I would say.
Thank you for phrasing it like that. And I know that we have a lot of questions. We could continue this conversation for another hour, but we are at time. So to wrap up, I know this time would have happened, but on behalf of the faculty, students, and staff at NYU's Robert F. Wagner Graduate School of Public Service, just like to thank our panelists for sharing their experience and talent and time with us this evening. Your comments and responses to our questions really have helped us get a wider frame of how healthcare must be transformed, and based on the experience that we saw last year. Thanks for your service in healthcare and whatever role you played, where healthcare was really on center stage. I would also like to thank you, our attendees, for attending this event, and we look forward to your continued engagement with Wagner events for the rest of the year, and at the 25th Kovner-Behrman Forum in 2022. So do have a good evening, and thank you for attending.